10. Good afternoon to the colleagues connected from Italy and other countries. For people not present at the previous meeting, for the last time, I will introduce myself. I'm Giuseppe Lorusso and I work as oncologist at the thoracic unit of the Istituto Nazionale dei Tumori of Milan in Italy. We arrived at the last meeting of our conference. For me, it was a great opportunity for personal and professional growth. I'm sure that also this meeting, as the previous ones, will be a success, both for the high quality of the presentation and for the number of people connected. Also today, the meeting will last 2 hours. Today, the speakers will talk about the last updates for treatment of patients with oncogene-addicted advanced non-small cell lung cancer. Dr. Rolfo will report news in regards to the role of liquid biopsy. Dr. Gagil and Dr. Philippe will discuss the treatment algorithm in patients with EGFR, ALK, and ROS1 aberration. Finally, Diego Signorelli will make an overview about rare targets. So, let me introduce my mentor and my great friend, Dr. Marina Garassino from Chicago University. Marina, can you say some words to the audience?
I am so happy to see you again for this last event, and I'm sure that it is a success, and I hope that it will become a tradition from the National Cancer Institute and also from Chicago. And we have an excellent panel of people, and I'm very happy to listen to all the presentations. And ciao, Claudia.
Thanks, Marina. Let me to introduce my colleagues that will be the chairs of these meetings. Dr. Claudia Proto and Dr. Giulia Galli. They both work with me at the Istituto Nazionale of Tumori in Milan. Claudia is here with me, and Giulia is connected from her home because she had a baby a few months ago and she is on maternity leave. Claudia, you have the floor.
Good evening, everybody. First of all, I would like to thank Giuseppe for this kind opportunity to be part of this very interesting and amazing meeting. Unfortunately, also this year, it was not possible to meet face-to-face the speakers and the audience, but we hope it will be possible next year. Anyway, for me and for my colleague, Dr. Galli, it is a great pleasure to open this very interesting session today that will talk about the recent advances in the treatment of non-small cell lung cancer characterized by driver alterations. Before starting, I have to remind you that we will start before with all the presentation, and then we will have time for questions and discussion during the round table. But anyway, for the virtual audience, I want to remind that it is possible to ask a question using the web live chat. So, let's start with the program of this session, and let me to introduce the first speaker, Dr. Christian Rolfo. Dr. Rolfo is the Associate Director at the Tisch Cancer Institute in New York. He will talk about the liquid biopsy. Are we ready for the use in clinical practice? Welcome, Dr. Rolfo.
Hi, thank you. Thank you for the invitation. Buongiorno to everyone. For me, it's buongiorno. For you is in the afternoon, but it's a pleasure to be here to discuss about liquid biopsy, and I would like to thank to Marina and to all the organizers of this important session. So if I have my slides, I can start to discuss. Perfect. So I say the title, when I saw the title, I say I will read it really ready for the print time. I say we are already in the print time from a long time ago. So I put another title that I think will be interesting for the discussion. So to know everything what we want to know about the liquid biopsies. That's our, I try to move, but I can't, that's are my disclosures. You know, living in New York, you have the opportunity to see some of the Hollywood stars sometimes, and I was really meeting last week twice, for twice Woody Allen that you have here, and this is one of the famous film, and I say why not to reproduce that in a talk, and you have here also some of the speakers, as you see Dr. Garasino have a very Hollywood picture there in the first slides. So going to the topic, when we are talking about liquid biopsy, we don't need to forget about tissue biopsy, obviously. And one of the advantages of liquid biopsies over the tissue is the opportunity to capture all the heterogeneity that is circulating in the bloodstream. Obviously, another advantage is that we can have a very continuous taking this in monitoring setting. We can take this blood drawing monitoring setting, and actually we are using that. Some companies in the United States, they are proposing now to use after 6 weeks of the first liquid biopsy when the patient have a TKI positive driver alteration, we can repeat after 6 weeks to see if the allelic fraction variation is decreasing, and that is a surrogate of a progression-free survival. It's true that some of disadvantage is that some patients are not able to be shedders, so they are not releasing in the bloodstream the quantity sufficient of ctDNA, and in that cases, obviously liquid biopsy is not the best choice, but tissue biopsy could be an opportunity for these patients. Heterogeneity is an important concept, and I want to stress this because we are not talking only about intratumoral heterogeneity, but also intrapatient. And that is an important concept when we are treating patients with TKI, because we know that some of the clones can take the lead in some moment of the disease, and we can have different behaviors of the disease that we can tailor it perfectly with the treatment. We would like to have a tool that is obviously applicable in all the journey of the patient, during all the journey of the patient, and we accumulate several robustness on the data of the metastatic disease. As you see here, the opportunity not only to detect the alterations, aberrations, and mutations, fusions, and other genomic aberrations, but also the possibility to monitoring the patients, and that is a very important concept. The big problem that we have still in United States, but it's also in around the world, I would say, is that majority of our patients are not testing. So if you see here, some of them, for example, with ALK, BRAF, EGFR, and ROS, that are I would say are not even covering the minimal requirement. This study was presented in ASCO this year. You see also, including the PD-L1, some of the patients are not even arriving to the 50% for the determination. So this is a big problem, and we need to do something, because if you see, for example, in this study from 2018 until 2020, the increase of the detection of the use of next-generation sequencing, and here we are talking together of liquid and tissue biopsy, is really very slow compared with the big success of the approval drugs that we have in the last years by FDA. So there is something that we are doing wrong. Here we have also another problem, that is disparities, and if we are putting the same study that was also presented in ASCO, a similar study for disparity, 39% of African American population, for example, is tested. That is a really low number. So that is something that we need to keep in mind and try to test our patients. So one of the studies that was giving robustness in this idea to test liquid and tissue biopsy together, or at least to have blood first, was this study that is the Nile. And in this study that was published in 2019, as you can see in this graphic, in the bar graphic, the blue areas are the negative or the quantity non-sufficient for tissue in these patients. You see that it's a very important number of patients that we are not testing with the tissue biopsy. And when we are adding liquid biopsy, there is not only a high concordance, but there is also an increase of the detection by 48% when we are doing the dual or the combo tissue and liquid biopsy. Obviously, there is a decrease of the time to wait for the results, and that is something that we see here when we are doing both at the same time. We see patients that we are starting the treatment with the liquid biopsy, and after they are already responding, we receive the results of the tissue biopsy. So blood first is a good opportunity, and that was also studied in this study we have today. Dr. Gagel and Shirish was presented the data of ALK in this study that is a prospective analysis that is called BFAST, using blood as an only source. Some of the cohorts are close, like the red. Obviously, it was not the good marriage here between the alectinib and red. And the others that we saw recently in ESMO, this blood TMB, was also negative. There are several things that we can discuss in the discussion about TMB. But in this cohort of ALK patients, the response rate were very high. Actually, if you compare with Alex trial, is not to compare the percentage of the response, but is to compare the magnitude of the response. And in the Alex trial that were using tissue biopsy, the response rate were also similar that we have in liquid biopsy. So blood first could be a good opportunity. In 2018, we published the ILCC first statement paper for liquid biopsy, and we put at that time liquid biopsy after, so it means sequential after tissue biopsy insufficient. So that was the first for the first line, and then in patients who were progressing to TKI, we put their liquid biopsy as an option, first option for mechanism of resistance. So we didn't include more than first option in after sequential and an option for detect the resistance. So we was not talking about other approach. And nowadays, in the recent publication that was presented in October 16, we have here a good opportunity to see how the liquid biopsy is going to be a complementary approach with the data that we have, and it's actually what we are doing in clinical practice, at least in our institution. And the plasma first approach, we also have this opportunity for patients. We include also an important part here that is the monitoring, the capacity of monitoring these patients during the time. Another players entering in the since 2018 to now, we have new fusions and fusions that are easy to be detected in liquid biopsy. That is the case of NTRK fusions, and NTRK genes that are 3 are very promiscuous in the number of fusions that they can have. So it's very difficult to have technologically an opportunity to capture all the partner fusions in one platform. So in the beginning, we have only the opportunity to do that with NTRK1, and that is the publication that we recently have. This is a case, for example, of a lung cancer patient with a EGFR resistant and raised NTRK fusion, treated with the NTRK fusion as well and responding. But you see that nowadays this is another opportunity to think outside the box and to test patients also in fusions that are not the first option for the patient, but having this opportunity is very interesting. And talking about thinking outside the box, this is a case of a patient with a small cell lung cancer. It's a really anecdotal case, but it's interesting to see that, for example, this patient was having an affuroblast growth factor receptor amplification detected in the liquid biopsy in third line after third line, and was an important decrease during the period of time, and she was surviving 1 year more with this pasopanib off-label medication. So we need to try to open a little bit our mind and use liquid biopsy in other indications, because in some patients we are doing the difference. Moving to another scenario, this is minimal residual disease, and here we have a lot of trials going on and a lot of research in place, and two differences in the approach that of the major technologies that we have at the moment, where the TracerX approach, that is the group of Charles Swanton from UK, and in this approach is departing from the tumor-informed approach, so departing from the tissue. The second one is the CAP-seq, that is an approach from directly from the liquid biopsy using next-generation sequencing. And in the first one, that is, I think, is a very elegant trial. I would like that. I would suggest that you read the paper, because it's one of the most beautiful papers that I read in liquid biopsy, I would say, because it's the opportunity to depart from this segmentation of sampling from different areas of the tumor, going to the creation of these phylogenetic trees that are containing the information of clonal and subclonal single nuclear variants, and from there going to the creation of a library for multiplex PCR for patients, up to 10 patients in liquid biopsy, to create this branch from the pre-surgery and have relapse. So it's a very personal approach. You see here in this slide different patients, that every figure is a different patient. And some patients like this one, for example, have number G, or I don't know if I can point, but the G, the patient G, you see that there is a decrease of the clonal and subclonal in the blood, but then it's at day 77, there is an increase, so this patient is having a recurrence. The next patient, that is the H, for example, you see that there is a decrease in the chemo during the chemotherapy and actually chemoradiation, and this patient is not relapsing. So having this opportunity to see even patients like, for example, number B or patient B, you have there a patient that is progressing during the chemotherapy. That patient could be maybe not sensitive or resistant to chemotherapy, and that is important to tailor as well. Another approach, I say, is the CAP-seq, is using 176 genes in the blood, and the opportunity to test these patients. The allelic fraction variation is really, really good. It's 0.02. And you have here a case also of not resected, but it's the stage 3 chemoradiation, and the opportunity also to see in these patients. What they saw generally is the detection or not detection of the ctDNA, and that is a surrogate of these dynamics, are a surrogate of progression-free survival, and in this case of the recurrence. So you have here a case of a patient with an equivocal progression in the PET-CT scan, but finally was a fibrosis. But in the ctDNA was really clear that this patient was not progressing. So that could be a very good tool to have these situations that we are struggling with, equivocal or even pseudo-progression or oligoprogression, to detect these patients. There is a new approach that was presented in World Lung Cancer for lung, but for lung approach, but is known already in colorectal cancer. Is the study, the REVEAL study, is the same technology, so methylation, ctDNA, and genomic alterations put in together in a target capture of 5.3 megabase, so it's a very important number of genomic alterations. And with only one time point, they are able to see the opportunity of these patients to have a recurrence. So this is an interesting approach, because it's using only one time point and it's not monitoring the patients during the after the surgery. So it's a really interesting approach. We will see what happened. This was a proof of concept only, or a pilot project. We will see what happened in large scale protocols. So we are waiting for these results. And obviously, speaking about clinical trials, there are opportunities for detect different scenarios, or to find different scenarios to have minimal residual disease answers for these patients using liquid biopsies. And some of the studies, like these mermaid studies, will be an answer of that. That's our prospective studies using liquid biopsy as a tool for minimal residual disease detection, and the allocation of this in patients in randomized trials for doublet of chemotherapy and immunotherapy, or monotherapy immunotherapy alone. So we will see what happens in the context also of the results that we have from other studies in immunotherapy. This is a very interesting scenario, that is the minimal residual disease applicable in immunotherapy after consolidation. And this is a retrospective analysis who showed what happened with patients after chemoradiation receiving or not immunotherapy. And as you can see there, some patients in the Kaplan-Meier curves, some patients have not detectable disease and were having a better prognosis in terms of progression-free survival, but also the opportunity to capture patients or to saving patients of treatment toxicities when really is not necessary. In the case, for example, of the second patient, you see that there is a decrease of the ctDNA in purple, but in green, the RECIST criteria were not really confirming that patient have actually a pneumonitis grade 5, and finally, unfortunately, dead for this cause. So saving patients from unnecessary treatment will be also a good opportunity for these patients. So I would like to see this in a clinical trial, prospective clinical trial, and see what happened. And finally, moving to the last scenario, that is the screening and the minimal residual disease, and the last frontier is the cancer interception. We need to have a technology that is really able to capture minimal disease and small lesions, small nodules. So there are some technologies in that regard. And obviously we have cytology, the things are better. But if we don't have cytology, in that cases, we can use, for example, methylation. And methylation actually was one of the major topics or fashion topic at the moment, because they are in process to get the approval by FDA. There are different panels. One of the panels is a multi-cancer detection test, and the others are directed only to one single organ or single tumor type. And obviously there are several questions here about sensitivity and one fit for all approach, if it's really useful. So what we saw in this trial, in this technology that is using methylation, and you have here the publications in 2020 and 2021. This year in ESMO, they were presenting why methylation is performing better than other alterations in the blood. And that is what I call the Ariana treat, because they back to the origin really at the end of the publications. And we saw that the whole genome methylation was performing better than even the PAM feature panel. So you have there, for example, the single nucleotide variants, also the fragmentomics of the fragment lengths and endpoints. If we are talking about the sensitivity, we need to check before the specificity. In this case, the specificity is very high, 98%. And you see that the sensitivity was 34 in this area. In the final publication, when we are putting together all the patients that you see there in the trial, were included not only cancer and not cancer, but inside the cancer population, we have also hematological disease. And inside the patient's characteristic and staging, we have also stage 1 and 4. Sensitivity for these patients was around sensitivity was 51.5 with a specificity of 99.5. But look at the differences between the tumor types. So if we are looking specifically lung cancer, we are talking about a 74.8% of all the stage. And if we are looking this difference in stage, you see here, for example, lung cancer in stage 1 is performing around 21%. All the tumor types in stage 1 is only 16.8%. And looking also for some differences in subtypes, you see that in this is not in the publication, this is not in no one of the publication, but there are some data presented in ESMO 2019 in preliminary, that you see that the adenocarcinoma is performing worse than the squamous in lung cancer, and also some other difference when we are talking about multiple or multi-cancer is the breast cancer, for example, hormonopositive and hormononegative, that are differences. So there is questions still there. Talking about fragments, the size of fragmentomics is very complex because there are several interactions that we can have to or that can interfere in the results. But this other study that is using a technology called Delphi with a specificity that is lower. The sensitivity also was not really great, but is there for stage 1, 2, and 3. They did also invalidation, but also they include here a benign nodal population. That's very important because we are including patients with high risk population that in the other study with the other technology of methylation are not including. Also, another important information is the cancer origin is easy, the cancer signal origin is easy to find when we have this methylation in 88.7%. So if you're looking the table, I don't know if you're able to see here, but we are talking about lung cancer here from 240 cases. Some cases were confused with kidney or head and neck cancer. So even though it's a very, very high sensitivity for cancer origin, and that is important for unknown primary tumors as well. There is also the opportunity to use methylation in combination with radiomics, and that is a very interesting approach. It was presented also this year, and it's interesting to see that they have also a good specificity and sensitivity that is around 30% for nodules that are really, really low, so in diameters, 5 to 10 millimeters. So that's a very interesting approach, and we will hear more about that. And finally, the cancer interception, that is the opportunity to capture the process that are leading the cancer creation with liquid biopsy. There are several studies on that regard. I will show you some of them, but also the model of metastasis interception that is also or recurrence interception using tissue or liquid alone, like we saw, could also increase the survival rates and the cancer control. And here you have, for example, one of these cancer interception projects that is patients with COPD or lung cancer are sharing similar mechanisms of the process, and part of these epithelial mesenchymal transition changes are leading by exosomes, for example. So there are several studies using extracellular vesicles, for example, to get this information, and we will hear more with platelets also in the future about this process because we can explain a little bit better the biology. So if we are going, I don't know if for sure Marina remember this film. I don't know if the young oncologists already they saw that, but the future seems very promising now. So having this opportunity to see in the future, I hope that it's not like the doctor here seeing that there are people that still is not testing in the future. So I leave you with this invitation. We just finished the ISLB Congress, and you have all the virtual presentations there. And here I leave you with my Twitter and my email for any questions that I will be happy to answer later on. Thank you for your attention.
Thank you, Dr. Rolfo, for your amazing presentation. Maybe we have to check if there is Julia. Okay, Julia, you can introduce the next speaker.
Thank you, Dr. Rolfo, for your...
We have some problem with the
Yes, I'm
connection.
here. Can you hear me?
Yes.
Yes.
Okay, thank you, Dr. Rolfo, for your comprehensive presentation. I am pleased to welcome the second speaker, Dr. Shirish Gadgil from the Henry Ford Cancer Institute of Detroit. Today, he will share with us the more recent news for patients with advanced non-small cell lung cancer and EGFR mutations. So welcome, Dr. Gadgil.
Thank you to Marina, Giuseppe, Claudia, and Julia, and all the organizing committee for doing this. My task today is to sorry, my task today is to speak on EGFR mutated lung cancer. I'm getting a little bit of an echo. Is there something I'm doing that is wrong? Okay. So we can go to the next slide. These are my disclosures. Next slide. So before I get started, I want to say thank you to Dr. Rolfo. He did a fantastic presentation. I would also like to thank him for using a very young picture of mine. I was like 15 years younger. Thank you very much, Christian, for using that picture. So as I mentioned today, my topic is to talk about EGFR mutation subtypes. And we are used to seeing these pie charts for lung adenocarcinoma. But this is not pie chart for lung adenocarcinoma. This is a pie chart for EGFR mutation lung cancers. It's important to note that even though our focus for the last 16 years has been primarily on the exon 19 deletion and exon 21 L858R mutation, we always knew about other EGFR mutations that occur in about 10 to 15% of EGFR mutation positive non-small cell lung cancer patients. But because testing was in the beginning for the last almost 10 to 15 years restricted to testing for the exon 19 deletion and L858R mutation, we were not able to detect patients who had these other EGFR mutations. But as we are transitioning to NGS testing, we are detecting more and more patients with these so-called uncommon mutations, with exon 20 insertions being the most common of those other mutations. And I'll talk about that later on. Next slide. So I wanted to discuss very briefly where we are. I think this audience knows that the current standard of care is to use third generation EGFR TKI, but I think it is important to put the data in perspective. When the second generation EGFR inhibitors were introduced, afatinib and dacometinib, the data suggested that these provide somewhat of a better outcome as compared to the first generation EGFR inhibitors, erlotinib and gefitinib. Particularly in the dacometinib trial, Archer 1050, if you look at the overall survival, it was a promising overall survival of about 34 months with dacometinib as compared to about 26 months or so with the first generation EGFR inhibitors, suggesting that the second generation EGFR inhibitors provide greater benefit. Two important points to remember about the second generation EGFR inhibitors. They are quite potent inhibitors of wild type EGFR, and therefore with both these drugs, you see a lot more anti-EGFR toxicities such as rash and diarrhea than what is observed with the first generation EGFR inhibitors, and that does limit the ability to adequately deliver these drugs to EGFR mutation positive patients. And another important point to remember, particularly with the Archer 1050 study, is that it excluded patients with brain metastases. And so the data looks good, but there was a proportion of patients with EGFR mutation lung cancer that were not included. And I think these two data points have to be remembered while discussing the data with third generation drug osimertinib. Next slide. So we all are aware of the journey that osimertinib had. Osimertinib initially was introduced as a T790M inhibitor, a drug that is quite needed in patients who have had first generation and second generation EGFR inhibitors, because one of the common mechanisms of resistance, particularly with the first generation EGFR inhibitors, was T790M mutation. It was subsequently recognized that osimertinib can be quite effective in treatment-naive patients. And one of the important reasons is that it relatively spares wild-type EGFR, and it's much more selective for mutant EGFR. And based on the recognition that treatment-naive patients do well on osimertinib, the FLORA study was initiated that randomized patients with exon 19 deletion or L858R mutation to osimertinib, a first generation EGFR TKI, which was according to investigators' choice. Next slide. The primary endpoint of this study was progression-free survival, which is the curve on your left. And then the subsequent, and the curve on your right is the survival data. This is the survival data at the initial analysis in the publication by Dr. Soria and colleagues in the England Journal of Medicine in 2018. The primary endpoint, osimertinib did improve progression-free survival with almost doubling of the progression-free survival from 10.2 months to 18.9 months. That translated into a hazard ratio of 0.46. As far as survival is concerned, even though in the initial analysis there was no survival difference, though there was a trend to improve survival in patients who received osimertinib. Next slide. On the final analysis that was subsequently published again in the New England Journal of Medicine, so second publication, there was improvement in overall survival with a median overall survival of 38.6 months with osimertinib compared to 31.8 months with a hazard ratio of 0.8. Not a significant benefit, not a very high, big difference between the two arms, nonetheless statistically significant. Now, one needs to be mindful this was not the primary endpoint. Nonetheless, demonstrating a survival advantage is quite remarkable. Next slide. And the benefit appeared to be across all subtypes. I would like to highlight two major subtypes where there were, or subpopulations where osimertinib did not demonstrate a survival advantage. One is in the Asian population, and the numbers with Asian patients was actually higher than non-Asian patients. And also, when you look at the type of mutations in the second row from the bottom, there was a survival advantage seen in exon 19, but not so much in the L858R mutation. Now, this data have to be viewed with caution. This was not the primary endpoint, and this was subpopulation analysis. Nonetheless, it's important to note that there were populations that did not appear to derive the same extent of benefit with osimertinib, and there's a question as to whether this data could be utilized to develop the next generation combination trials. One needs to be mindful that about 50% of eligible patients crossed over to osimertinib among patients who were on the first generation EGFR inhibitors. Now that may seem low, but it's important to note that in many lung cancer studies, only about 50 to 70% of the patients land up getting second-line therapy. There are a group of patients that unfortunately pass away. And as you know, osimertinib is not indicated in all patients who get first-generation EGFR TKI because not every patient develops T790M mutation as the resistance mechanism. Next slide. Now, one of the most important, I don't know how well this is showing up online, but one of the important efficacy parameters of osimertinib is its activity against CNS metastases. This is a patient of mine who was 89 years old. She actually had received another third generation EGFR inhibitor called ruxolitinib that was being developed at the same time as osimertinib, but did not, due to a variety of reasons, move forward. And so this patient had derived clinical benefit for about 8 to 9 months on another third generation inhibitor after receiving benefit from first generation inhibitors, and then subsequently was treated with osimertinib and had asymptomatic brain metastases, which improved right away on the first scan done after 2 months of being on osimertinib. Now, about 2.5 years after starting on osimertinib, the patient eventually passed away. But what was interesting is she never developed a recurrence in the brain, and it's this efficacy against CNS metastases, in addition to its selectivity with regards to mutant EGFR as compared to wild-type EGFR, apart from the data from INFLORA study, that really has made osimertinib as the primary standard of care. Next slide. Now, we know that osimertinib provides improved outcomes, but a median survival of 38 months is not definitely something that we can be satisfied with. So the question is, how can we do better? Are there combination treatments that we can do that will improve the outcome? There has been a lot of interest with regards to VEGF inhibition and EGFR inhibition. Over 10 to 15 years ago, it was known that EGFR mutation positive lung cancer patients, lung cancer tumors rather, express a high level of angiogenic factors, and there was data, preclinical data to suggest that combination treatments of EGFR inhibition with VEGF inhibition may provide greater efficacy. Next slide. And so there have been trials that have been conducted both in Japan and ex-Japan, evaluating the addition of a VEGF inhibitor to EGFR inhibitors. This study was the NEJ026, combining erlotinib to bevacizumab. Primary endpoint was progression-free survival. And it did show an improvement in progression-free survival with a hazard ratio of 0.60 that translated into a median survival with a combination of 17 months. Next slide. However, there was no overall survival advantage seen with the combination. Next slide. The other study that was conducted was the relay trial. And by the way, this combination of erlotinib and ramucirumab, bevacizumab, as everybody is aware, binds to the VEGF ligand, whereas ramucirumab binds to VEGF receptor 2. So inhibits VEGF, but at a different point along the signaling pathway. So this combination is approved in the United States based on the relay trial that randomized patients with EGFR mutations to the combination versus erlotinib plus placebo. Important to note that this, like the Archer 1050 study, excluded patients with brain metastases. Next slide. And the primary endpoint was progression-free survival. And this combination did show interesting progression-free survival of 19.4 months compared to 12.4 months with erlotinib alone. And this is comparable to osimertinib. But mind you, again, like the Archer 1050 study, this study excluded patients with brain metastases. Next slide. There is some data to suggest that this combination may be more efficacious in L858R mutations, but we really don't have prospective data to show that this is better than osimertinib. Now, there is data of combining osimertinib with bevacizumab, and what has been shown is that there doesn't appear to be an improvement in efficacy when you combine anti-VEGF drugs with osimertinib. So the figures are from a paper evaluating the combination of bevacizumab with osimertinib in EGFR T790M. So these were patients who had received first generation or second generation EGFR inhibitors, had progressed and had T790M mutation. And the combination did not appear to show a significant benefit. Mind you, in the top figure shown here from the study, the blue curve is of osimertinib alone, and the yellow curve, which actually shows a slightly inferior outcome, is of the combination. At this year's ESMO, and I apologize, I don't have the figures from this presentation, there was a study again from Japan, WJOG 917L, that looked at the combination of osimertinib plus bevacizumab in treatment-naive patients. Now, and it did not show a benefit with the combination of osimertinib and bevacizumab. One important point to remember is this was, first of all, a randomized phase 2, so not a randomized phase 3. And in this study, they did include exon 20 mutations as well. And so this was not restricted to patients with exon 19 and L858R mutation. There is an ongoing study of osimertinib plus bevacizumab in the United States, which is an intergroup study that is restricted to patients with exon 19 and L858R mutation. Remains to be seen whether the combination will provide a greater benefit. Next slide. Another combination that has been evaluated is a combination with chemotherapy. This was the NEJ009, the same group that had done the osimertinib plus bevacizumab, erlotinib plus bevacizumab combination. This was a study conducted in Japan that randomized patients to gefitinib or gefitinib plus carboplatin pemetrexate chemotherapy, and found not only an improvement in progression-free survival, but an improvement in overall survival with a remarkable survival of 52 months with the combination of chemotherapy and gefitinib, and a hazard ratio for survival of 0.70. Quite promising results, though this is a study that was conducted only in Japan. Next slide. There was another study conducted in, next slide. There was another study conducted in India that was a little more real world. They included patients with performance status 2, and they randomized patients again to gefitinib versus gefitinib plus chemotherapy. Next slide. And this study also, interestingly, showed not only an improvement in progression-free survival, the curve to your left, but also an improvement in overall survival. Now, the numbers in this study, efficacy numbers, are somewhat lower than the Japanese study, probably because 22% of the patients were PS2 and 17% of the patients had brain metastases. But two studies conducted in two different countries showed a similar improvement in survival when combining chemotherapy with first generation EGFR inhibitors. Next slide. And so based on that data, there is a study that is ongoing, FLORA-2 study. Next slide. That is evaluating the combination of osimertinib plus chemotherapy, which will answer the question that can we build on the results of osimertinib observed in the FLORA trial. Next slide. Now, it seems a little too sort of unscientific, if I may say, where we treat every patient with combination. There are clearly patients who do well with single agent or osimertinib. I have patients now who are going on for more than 5 years on osimertinib as second line treatment. So it would be, in current day and age, I don't think would be a good strategy to expose every patient to the combination either with an anti-VEGF agent or with chemotherapy. Dr. Alford did a phenomenal job, but there is data to suggest that liquid biopsies done after the patient starts on treatment at 3 weeks or 12 weeks, and a change in ctDNA where it goes from detectable at baseline to undetectable. Those patients appear to do better than patients who have detectable ctDNA at baseline and continue to have detectable ctDNA at 3 weeks. And could we use such a tool to then treat such patients with combination therapy, and patients who don't have detectable ctDNA can continue on single agent osimertinib? And such trials definitely need to be performed so that we can personalize treatment rather than treat every patient with combination treatment. Next slide. So these are the first line options at the present time, and I recognize that there are countries where osimertinib may still not be available as frontline therapy. And I think in those patients where osimertinib is not available, based on the data available, I would prefer to treat those patients with chemotherapy and a first generation EGFR TKI, as shown in the Japanese and the Indian trial. Though you do have the options of using second generation EGFR TKI or a combination of VEGF plus EGFR, first generation EGFR. But where osimertinib is available, I do believe osimertinib should be the preferred choice as single agent at the present time. Next slide. Now, as everybody knows, osimertinib has moved into early stage disease. This is the ADAURA trial. Patients with stage 1B to 3A, according to the 7th edition TNM, were randomized to osimertinib or placebo after having received surgery and chemotherapy if the treating physician so desired. Next slide. And you've seen this, next slide, you've seen this data showing an improvement in the disease-free survival. What I would like to highlight is the fact that there did appear to be a difference based on stage. So the benefit was not as promising in stage 1B disease with 0.50. And the benefit was significantly greater in stage 2 and stage 3A. And even so, in my practice, I tend to use osimertinib in these stage 2, 3A patients. But I would also like to highlight something that I'm sure this audience has noticed, is that if you look at the yellow or the placebo curves, it's quite impressive what a great proportion of patients land up having disease progression. So at 3 years, almost 80 to 90% of the patients have disease progression in the placebo arm, suggesting that even though we only have disease-free survival advantage with osimertinib, and as yet we don't have overall survival advantage, I think there is clinically meaningful benefit from these data sets, and I would lean towards using using osimertinib, which is at least approved in the United States in the adjuvant setting. Next slide. Briefly going over progression, important to note there are different clinical types of progression. There's systemic progression and oligoprogression. And in oligoprogression, it is perfectly reasonable to use local treatment and continue on the EGFR TKI. In addition, there are some patients who have very slow progression. I had a patient who was on erlotinib for more than 2 years after the CT scan had shown progression. So just because there's progression doesn't automatically mean every patient that you have to switch treatments. Next slide. However, what is very clear is that with any of these EGFR TKIs, including third generation, there are tumor progression does eventually occur, and we know more and more now about the mechanisms of resistance, particularly with frontline osimertinib. You don't see T790M, but you do see MET amplification and EGFR mutations such as C797X. There are other alternative pathway activations such as BRAF mutations as well as RET translocations, and there are case reports of using drugs targeting these alterations but continuing osimertinib that have shown some clinical benefit. Next slide. Important to note that there are at least two different mutations that have been recognized, C797S, and there's data to show, at least preclinically, that if you combine a first generation inhibitor, because first generation inhibitors do inhibit C797S, combined with osimertinib appears to provide anti-tumor effect. Again, preclinical data, though there are more and more clinical reports coming up. And there's data to show that the second generation EGFR inhibitor, afatinib, does appear to have benefit against a different mutation, G724S. So do recognize that if a resistant mechanism mutation arises, that previous generations of EGFR inhibitors may be beneficial. Next slide. Now, there is also data about MET amplification, and using a MET inhibitor such as savolitinib combined with osimertinib that has shown some benefit. I will say the benefit is relatively modest with a response rate of 25%, but activity can be seen. Next slide. But now we have two different drugs or one drug and a combination of drugs that has at this year's ASCO showed benefit in patients who had resistance to EGFR TKIs. One is a HER3 directed antibody drug conjugate, patritumab deruxtecan. This has the same payload as trastuzumab deruxtecan, the drug that is approved in breast cancer and gastric cancer, where the antibody, instead of HER2, as in trastuzumab deruxtecan, is directed to HER3, which is expressed in over 80% of non-small cell lung cancers. HER3 expression itself doesn't appear to have a biological relevance. Next slide. And this drug, at least in the single-arm phase 2 study presented by Dr. Pasiani at ASCO, showed a very promising response rate of 40%. I apologize, I'm showing the waterfall plot, but the response rate was 40% with a median progression-free survival of about 8 months. So promising activity, and what was seen in this waterfall plot or in this figure is that benefit was seen irrespective of the mechanism of resistance, suggesting that this drug could have activity in this patient population. Next slide. And another one important thing to remember is that the drug does have similar toxicities such as trastuzumab deruxtecan, including interstitial lung disease seen in about 7 to 10% of the patients. Next slide. And another combination presented at ASCO this year was the combination of amivantamab and lazertinib in patients who had received EGFR TKIs before, including osimertinib. Lazertinib is another third-generation EGFR inhibitor, and amivantamab is a bispecific antibody targeting EGFR and MET. Next slide. And this combination was evaluated in a study where in the first cohort, amivantamab, the bispecific antibody, was administered by itself, and in another cohort, the combination was administered, and it appeared that the combination had better activity with a slightly higher response rate, but a longer median duration of response. Next slide. And this, there was a biomarker they came up with that showed maybe quite predictive of benefit. Next slide. EGFR MET expression. I'm going to quickly finish off by talking about exon 20 mutations. Kindly note that there are many different exon 20 mutations, and some of the C helix mutations, 761, 762, may be sensitive to earlier generations of EGFR TKIs. Next slide. We have now two drugs approved. One is amivantamab, which I mentioned before. Next slide. that showed a response rate of 40% and a median progression-free survival of about 7 months and a median duration of response of 11 months. Next slide. This drug does have a unique side effects. It does have the EGFR side effects such as rash and diarrhea, but it also has an infusion reaction seen in about 60% of the patients. And usually it is restricted to first dose, and therefore the first dose is given over 2 days. Next slide. And another drug is an EGFR TKI, mobocertinib, that showed a response rate of 28%, somewhat less, but the median duration of response was 11 months to 17 months. Next slide. One of the important adverse effects of this drug is the EGFR toxicity, diarrhea being the dominant one, with 90% of the patients experiencing toxicity. Next slide. So this is the algorithm at the present time in EGFR mutation positive patients, particularly the exon 19 and ALT58R mutation. Generally start with third generation agent osimertinib. But then when the patient progresses, we can have a different combinations used based on what the molecular mechanism of resistance is. I did not discuss immunotherapy, but immunotherapy, at least the immunotherapy agents that we are currently using, are not very effective and are usually reserved for much later lines of therapy in this patient population. Thank you very much. I hope I didn't go over too long.
Thank you very much, Dr. Gagil, for your very interesting and complete overview. Now let's move to the next speaker, and I am very glad and honored to welcome Dr. Enriqueta Felipe from Vall d'Hebron Institute in Barcelona. She will talk about current treatment algorithms for ALK and ROS1 positive patients. Good evening, Dr. Felipe.
Good evening, and thank you so much for your kind introduction, and also thank you to my friends, Dr. Marina Garasino and Dr. Loruria for inviting this meeting. So I'm going to current treatment algorithm ALK and ROS1 positive patients. So next slide, please. You can see my declaration of interest. Next slide, please. During this presentation, we are reviewing ROS and ALK. When we analyze ALK fusions are present in approximately 4.4% of the patients with metastatic disease. ROS is present in 2% of the patients with metastatic lung adenocarcinoma. When we analyze these molecular alterations in early stage disease, we have less information, but in general, it seems that the molecular alterations in patients with early stage disease are slightly seen in a lower frequency. Next slide, please. So we are going to start with ALK. As you know, ALK is associated with adenocarcinoma histology. It's also associated with never smoker, light former smoking history, and younger age at diagnosis. The median age of patients with ALK positive tumors is approximately 50 years at diagnosis, and we know that ALK is mutually exclusive with other oncogenic driver mutations. In patients with ALK, brain metastases and pleural and pericardial effusions are common at disease presentation, and we can see thromboembolic events. We can have the testing for ALK using 3 different methods: FISH, immunohistochemistry, and NGS. And in all this, with all these 3 methods, there is enough to treat the patients with ALK inhibitors. Next slide, please. So the first agent analyzed in ALK-positive tumors was crizotinib. Crizotinib was analyzed in 2 phase 3 trials, one in second line and the profile 1014 in first line in patients with ALK-positive tumors determined by FISH. In this trial, patients were randomized to receive platinum pemetrexed or crizotinib, and this is a trial is positive. Crizotinib achieved a longer progression-free survival when compared to platinum pemetrexed with a hazard ratio of 0.45. Crizotinib was associated with a response rate in 74% of the patients, and this trial established crizotinib as the treatment of choice for patients treatment naive and ALK-positive tumors. Next slide, please. We have learned also profile that patients with positive tumors had longer survival. 6% 4 years, and the survival not years, overall survivals longer than 5 years. Next slide, please. And the next step in patients treatment naive were randomized trials. We have the ASTEN-1 trial comparing versus chemotherapy, but we have also randomized trials in line comparison crizotinib. All the groups.
We are sorry, but we have some problem with the connection. So, Dr. Felipe, do you hear us?
Yeah.
Yes.
Yeah.
You can try to go on if you want.
Sorry for that, because yes, I'm in my office and it seems there is problems with connection, but I will try. So I was mentioning that in the randomized trials in first line comparing alectinib, brigatinib, ensartinib, and lorlatinib versus crizotinib, all trials show longer progression-free survival with the second and first generation ALK inhibitors when compared to crizotinib, the first generation ALK inhibitor. Next slide, please. Another important activity for second and third generation ALK inhibitors are the CNS activity. In the ALTA-1L trial, ALEX trial, Crohn trial, and in the ensartinib trial, we have seen that the activity of alectinib, brigatinib, ensartinib, and lorlatinib is higher in CNS when compared to crizotinib. Next slide, please. So we can have here the results of the ALEX trial. In the first line treatment, alectinib was associated with a median progression-free survival of 34 months, according to the investigator, and also there was longer overall survival with alectinib when compared to crizotinib. Next slide. We have also the updated results of the ALTA-1L trial with brigatinib versus crizotinib. Again, in this final analysis, the progression-free survival was longer with brigatinib when compared to crizotinib with a hazard ratio of 0.45. The difference in this study is that patients with prior chemotherapy, one line, were allowed to be included in the trial. Also important for those patients with metastatic brain metastasis at baseline, there was a clear longer progression-free survival in the brain for those patients treated with brigatinib when compared to crizotinib. Next slide, please. The results of ensartinib versus crizotinib have been published recently in JAMA Oncology. Again, it's a positive result, the same thing, a longer progression-free survival with ensartinib when compared to crizotinib. Next slide, please. And finally, the Crown trial in first line comparing lorlatinib versus crizotinib, longer progression-free survival lorlatinib with a very good hazard ratio, and also longer intracranial time to progression with lorlatinib when compared to crizotinib. Next slide, please. We have also the results of the BFAST trial in patients with ALK-positive tumors detected by blood NGS and treated with alectinib. So in this group of patients determined by blood liquid biopsy, the results with alectinib are exactly the same when we use tumor biopsy. So the conclusion of this analysis is that we can use the liquid biopsy analysis of ALK for treating our patients with first-line alectinib. Next slide, please. During these years, we have learned the mechanisms of acquired resistance in patients with ALK-positive tumors. We have ALK-dependent mechanisms of resistance. The most important are the secondary resistance mutations, but also ALK amplifications. And we have ALK-independent mechanisms of resistance, those patients with heterogeneity and also a small cell lung cancer transformation, but also bypass tract activations. And there are patients with activation of EGFR, MAP pathway, or also MET amplification as a mechanism of acquired resistance. We have seen that after second generation ALK inhibitors, there are approximately 50% of patients with secondary ALK mutations, and in the vast majority of cases, the most prevalent is the G1202R mutation. Next slide, please. And also MET amplification is also a common mechanism of acquired resistance. In this paper, approximately 15% of patients with ALK resistance have MET amplification as a mechanism of acquired resistance. And there is also one case of a patient with MET amplification as a mechanism of resistance treated with crizotinib. Crizotinib is also a MET inhibitor and also with a very good outcome. Next slide, please. So at present, I think all the guidelines recommend to use a second or third generation ALK inhibitor first in the first line setting. These agents are associated with a high activity, but importantly, these agents have a higher CNS activity. So the next question is the treatment in those patients after second generation ALK TKI. Next slide, please. We all have seen this slide showing different cell lines with different ALK secondary mutations. And for those cell lines with the G1202R mutation, we can see that the most optimal IC50 is for lorlatinib, a third generation ALK TKI. Next slide, please. And we have results of lorlatinib in a phase 1 trial in patients with ALK-positive tumors. In this trial, the response rate with lorlatinib after ALK inhibitors was 46%. It was 57% for those patients with one prior ALK TKI. It was 47% for those patients with 2 or more prior ALK TKIs. Next slide, please. And the next step was a phase 2 trial with lorlatinib in a different cohorts of patients. There is the cohort of patients with 2 prior ALK inhibitors plus minus of chemotherapy, and also a cohort of patients with 3 prior ALK inhibitors plus minus chemotherapy. So a total of 111 patients were analyzed. 75% of these patients had brain metastases at baseline, and lorlatinib was associated with a response rate of 40%. The intracranial response rate was 53%. The median duration of response was not reached, and the median progression-free survival was 7 months. Next slide, please. We have seen that lorlatinib is active in presence of the secondary mechanisms of secondary mutations. In the presence of the G1202R, there is a 57 response rate, but we can see also responses in patients with different types of secondary ALK mutations. Next slide, please. But we have seen responses with lorlatinib in the presence of secondary ALK resistance mutations, but also for those patients without these secondary mutations. Next slide. This analysis was presented during the ESMO meeting in patients previously treated and that received lorlatinib. Dr. Solomon presented the results according to the concomitant p53 mutations. For those patients with ALK and concomitant p53 mutation, the progression-free survival with lorlatinib seems slightly lower when compared to those patients with concomitant p53 wild type. But at present, we don't know if p53 here is predictive or prognostic. Next slide, please. We have seen that after lorlatinib in patients previously treated with other ALK inhibitors, the compound mutations confers resistance to this agent. Next slide. But there is a presentation at ASCO from liquid biopsy in patients included in the CROWN trial in the first line. In this trial, liquid biopsy was performed just before starting treatment at 4 weeks and at 4. And we have seen that most patients had early decrease in the ALK allelic fraction, but this decrease was less sustained in crizotinib treatment patients. And perhaps clonal resistance mechanism may be covered by lorlatinib. Next slide, please. The toxicity associated with these agents is slightly different. With alectinib, we can see myalgias and also in some cases transaminases increase. With brigatinib, increase in CPK and also this lung toxicity of early onset. With lorlatinib, we have hyperlipidemias and also cognitive and mood adverse events. Next slide, please. There is some studies showing that platinum pemetrexed is also a good chemotherapy for these patients after progressing to second-generation ALK inhibitors and also third-generation ALK inhibitors. We don't know for sure. This is a retrospective analysis of a group of patients. In this analysis, those patients with who receive chemotherapy and also with ALK inhibitor had slightly longer progression-free survival, but again, this is a retrospective analysis, and I think for those patients who receive chemotherapy, we should stop the prior ALK inhibitor. Next slide, please. And immunotherapy is not really active in patients with ALK-positive tumors. We know that the tumor mutational burden in these patients is low, and also we have seen during the World Conference in Lung Cancer a study analyzing chemotherapy plus pembrolizumab in patients with EGFR and ALK alterations. In patients with ALK alterations, the number is rather small, but the response rate is really moderate and median progression-free survival of 2 months. So no major activity, in my opinion, of immunotherapy in these patients without positive tumors. Next slide. We have 2 trials analyzing ALK inhibitors in the adjuvant setting. The ALINA trial compares in patients with resected tumors, compare chemotherapy versus alectinib, and also we have the Alchemist trial analyzing crizotinib versus placebo, and in this trial, adjuvant chemotherapy before the randomization may be considered. So next slide. ROS, we have mentioned approximately 2% of all lung adenocarcinomas. We can see ROS in patients with lung cancer, but also in other tumor types. ROS and ALK domains have significant similarities, and ROS1 positive patients share many characteristics when compared to ALK positive patients. So adenocarcinoma histology, younger age at diagnosis, and also seen in never or light smokers. Next slide, please. In ALK, in ROS, we can use FISH for determination and also NGS. Also, we can use immunohistochemistry, but we know that there are some tumors positive for immunohistochemistry for ROS, and these patients may be a false positive. So in this case, for those patients positive with immunohistochemistry, there is a need for confirmation using FISH or NGS. Next slide, please. Profile 1001 established crizotinib as a treatment of choice in patients with ROS1 positive tumors, achieving median progression-free survival of 19 months in a group of patients. So very good results in this molecular subset. Next slide. Almost immediately, it was described the G2032R as a secondary mechanism of acquired resistance in ROS. Next slide. And in a publication for Dr. Gaynor, he presented data in 16 patients with ROS1 positive tumors treated with crizotinib, and the G2032R was present in the 53% of rebiopsies. So this is really a considerable number of patients after crizotinib failure. Next slide, please. We have other agents active in patients with ROS. We have data with ceritinib that was analyzed in a phase 2 trial. Ceritinib was active in patients treatment naive. There are 2 patients previously treated with crizotinib, but the majority of patients were treatment naive. Next slide. Next. We have also the results with entrectinib in patients with ROS1 positive tumors. So in general, in this trial, patients with no prior ROS inhibitor were included, very good responses, median progression-free survival, approximately 20 months, and again, very well-tolerated agent. So established crizotinib and also entrectinib as a first-line treatment approach for patients with ROS1 positive tumors. Next slide, please. We have data also with lorlatinib in ROS1 positive tumors. There are data in patients treatment naive, but also in patients previously treated. There is no clear information about that. Lorlatinib is active in patients previously treated with crizotinib, but there is no clear information about the activity of lorlatinib in the presence of the secondary ROS mutation. Next slide, please. Recently, it was presented also data with brigatinib in patients with ROS1 positive tumors previously treated with crizotinib. Again, we have seen responses with brigatinib in patients previously treated with crizotinib. Next slide. And finally, I would like to mention repotrectinib. This study, the Trident 1, is based on also in the preclinical information suggesting that this agent is active in presence of the G2032R mechanism of resistance. Repotrectinib is active in patients treatment naive, but also in patients previously treated, and in this trial, there is activity in patients with the G2032R mutations just before receiving repotrectinib. Next slide, please. So, in summary, we have seen long survival for patients with ALK and ROS positive tumors. There is a need for testing, and we can have some issues that, and now NGS is recognized as an important diagnostic tool. For ALK-positive tumors, second and third generation ALK TKIs obtain better results when compared to crizotinib in first-line treatment. For those patients previously treated with a second generation ALK TKI, lorlatinib has excellent activity. In ROS1, in the first line, we have crizotinib, we have entrectinib, we have also ceritinib, and in patients previously treated, we have interesting results with lorlatinib, brigatinib, and repotrectinib. And it's important to stress that more strategies for treatment resistance are needed. I would like to apologize for all the problems I had with the connection. Sorry for that, and thank you again for this opportunity.
Thank you, Dr. Felipe, for this brilliant presentation. Now let's go to the last presentation of this meeting. I'm very happy to introduce my friend, Dr. Diego Signorelli, who works at the Niguarda Cancer Center in Milan. He will update us about new targets, new therapies, and new toxicities in patients with advanced non-small cell lung cancer and rare driver mutation. Diego, you have the floor.
Thank you very much, Giulietta, for your kind introduction. Hello, everybody. First of all, grazie Giuseppe and Marina for the invitation. Firstly, for considering me still a young oncologist. It's always a pleasure, and especially for giving me the opportunity to be here and to talk about new targets, new therapies, new toxicities beyond EGFR, ALK, and ROS1 non-small cell lung cancer. Here are my disclosures. When Claudia, Giuseppe, and I met for the first time about 7 years ago, I think that we looked for only 3 main driver alterations. And this is my agenda today. And I have to delete some driver alterations because of the limited time. Moving on, let's start with BRAF. BRAF that is present in up to 5% in lung adenocarcinoma. It can be present in smokers and non-smokers, BRAF mutations, that are classically divided in 2 groups of mutations, V600E and the other ones. And we have already in clinical practice available the combination of the BRAF inhibitor dabrafenib with the MEK inhibitor trametinib, based on the results of the phase 2 trial published 4 years ago, that showed in first line a response rate of about 64% and a median OS of 25 months. The combination can be related to some toxicities. About 70% of the patients developed grade 3 or more toxicities, and 22% discontinued the drug because of adverse event. A specific adverse event is the squamous cell carcinoma, with a proportion lower in comparison with BRAF inhibitor monotherapy. Moving on to MET, the question is, but what does it mean, MET alterations? Because we can find MET exon skipping mutations or MET amplification. MET exon skipping mutations inhibit the degradation of the protein. They are present in up to 3-4% of non-small cell lung cancer, especially in old non-smoker female patients. And the sarcomatoid histotype, and are mutually exclusive with, generally mutually exclusive with other driver alterations, while MET amplification can be mechanisms of resistance of other TKIs and can be a driver alteration also present concomitant to MET exon skipping mutations. We have different kind of treatments available, in particular a class of specific MET inhibitor, class B, with tepotinib and capmatinib. Tepotinib and capmatinib were tested in 2 different trials with some differences in the study design. Vision trial tested tepotinib, and tepotinib was administered to all the patients with MET exon 14 skipping mutations in the same cohort, regardless of the line of treatment. While in geometry study, we find different cohorts according to the line of treatment of capmatinib. Furthermore, in vision study, patients could be enrolled according to both tissue and plasma analysis, while in geometry study, in the inclusion criteria, the analysis were performed only on tissue. But both treatments are effective. This slide summarizes the data that we have with MET TKIs in MET exon 14 skipping mutations. And as you can see, especially in the geometry study, the efficacy of capmatinib seems better in frontline setting, not only for the response rate that was the primary endpoint, but also for median duration of response and median PFS. In terms of safety, there are some side effects that are typical for this class of drugs, such as peripheral edema and increased in blood creatinine with a permanently discontinuation rate of about 11%. At the last ASCO Congress, data about amivantamab, the bispecific antibody, were presented. Preliminary data, small numbers, 19 patients, but signs of activity also in patients previously treated with MET TKIs. It's important to note that these patients can develop brain metastasis. Up to 40% of patients can develop brain metastasis, and geometry and vision studies showed CNS activity for both capmatinib and vision in terms of response rate or disease control rate. But studies evaluated also the role of MET TKIs in MET-amplified tumors. But we know that it's still an issue to define what is the cutoff, the correct cutoff to define a MET-amplified tumor. And the results were different from the promising results seen in MET skipping alteration, because probably not all MET amplified tumor, MET amplification is not always the right driver alteration of that tumor. And importantly, different studies used different cutoff to consider MET amplification. Regarding immunotherapy, these is a population that generally do not achieve benefit from immunotherapy, especially from immunotherapy alone. PD-L1 is not predictive. Disease has a low TMB. And so it's important to test MET disease regulation since the beginning, since the diagnosis of advanced disease. We can use NGS, real-time PCR, Sanger sequencing to detect MET exon 14 skipping mutations, or FISH or NGS to detect MET amplification. Moving on to HER2. Also for HER2, the question is, but what does it mean, HER2 alterations? We can find HER2 protein overexpression, HER2 gene amplification, or HER2 mutations in up to 4% of patients. And while HER2 protein overexpression and HER2 gene amplification can be also a mechanism of resistance to other TKIs, HER2 mutations generally are mutually exclusive with other oncogenic drivers. They are more frequent in younger non-smoker female patients, and they are associated with a higher proportion of brain metastases. Once again, the preliminary data with immunotherapy do not show a significant benefit, especially for immunotherapy alone for HER2 mutant lung cancer. And so we can use different mechanisms of action to treat these alterations. Starting from TKIs, at the last ESMO meeting 2 months ago, data from Zenith 20 trial were presented, specifically cohort 4. Patients were enrolled in first line with HER2 exon 20 insertions. Primary endpoint was objective response rate. It was about 44%, with 5.5 months of PFS. So, of course, activity of this drug, but we have to pay attention to the toxicities related to this drug. As you can see, all the patients developed treatment-related adverse events. 88% of the patients had to interrupt the drug, 77% had to reduce the drug, and 30 patients permanently discontinued the drug. Toxicities were especially gastrointestinal toxicities, such as diarrhea or stomatitis, and cutaneous toxicities with grade 3 rash in 35% of patients. In order to improve the toxicity profile of the drug, a new schedule is ongoing, 8 mg BID, that showed in comparison with the 16 mg QD similar efficacy and a better toxicity profile. Other kind of treatments are the antibody and drug conjugates, especially TDM1 and trastuzumab deruxtecan. At last ESMO meeting, data from DESTI-Lung01 phase 2 study with trastuzumab deruxtecan in the population of HER2 mutated patients were presented with a dose of 6.4 mg per kilo every 2 weeks. Asymptomatic CNS metastases were allowed. And I think that the results are very, very promising. We are talking about heavily pretreated patients. Trastuzumab deruxtecan could be also the 70th line of treatment. And as you can see, 55% of patients achieved a response rate, a partial response or a complete response, regardless of the kind of HER2 mutations or the presence or not of HER2 expression or HER2 gene amplification. Median PFS was 8.2 months with a median OS of about 18 months. So data very promising with some data of activity also with intracranial disease. Once again, pay attention to toxicities. We find toxicities commonly related to chemotherapy, such as neutropenia and anemia. 25% of patients discontinued the drugs because of treatment-related adverse events, and 2 patients died because of a specific side effect, that is the interstitial lung disease. It's typical of this drug, and it is important to strictly monitor these patients and to promptly start steroids. And this slide summarizes the data that we have to date in this population, HER2 mutant lung cancer, with TKIs, monoclonal antibodies, or antibody-drug conjugates. Moving on to RET. RET fusions are present in about 2% of patients, generally younger patients, never smoker, and up to half of these patients can develop brain metastases. The first studies with multi-kinase inhibitors did not show a significant benefit, probably because of the off-target toxicities that requested the reduction of the dose of the drugs. And also the data with immunotherapy, especially immunotherapy alone, do not show a significant benefit. But now we have two selective RET inhibitors, selpercatinib and pralsetinib, both showed efficacy in this setting, in this disease, and importantly, both showed an intracranial activity. The toxicity profile was excellent. There are some differences in some side effects because, for example, pralsetinib can inhibit JAK2, so we can see anemia or neutropenia. But if we look at the discontinuation rates, they were low for both drugs. Moving on, NTRK. NTRK is involved in the neuronal development, and it is a very rare driver alterations in non-small cell lung cancer, less than 1%. Even if rare, we have two drugs to date that can be active, that are effective in this disease, larotrectinib and entrectinib. Again, small numbers, but a response rate up to over to 70%. If the response rate is similar in patients with or without baseline brain metastasis, in terms of PFS and OS, they are lower in patients with brain metastasis in comparison with the patients without brain metastasis, for both for entrectinib and for larotrectinib, as you can see in this slide. Probably because CNS metastases are, of course, a negative prognostic factor. But once again, pay attention to the toxicities related to this drug, because they are typically due to the mechanism of action of these drugs. So there are patients that cannot develop any side effects, but we can see weight gain, dizziness or ataxia, withdrawal pain, paresthesia, and also mood disorders or cognitive impairment. So we have to strictly monitor these patients. Last but not least, KRAS. KRAS that is a driver present in about 25% in lung adenocarcinoma that for many years have been considered undruggable. But in the last years, we have some data from KRAS G12C inhibitors that can bind covalently the protein, occupy a pocket, when KRAS G12C is in its inactive GDP-bound state. And now we have the data from two drugs, so thoracic and adagrasib, that show an activity in this disease. As you can see, the last data from sotorasib coming from the ASCO of this year, 2021, 37% of response rate, 6.8 months of PFS, median PFS, and 12.5 months OS. Of course, there are not the same data that we achieved from TKIs of other driver alterations, such as EGFR, ALK, ROS1, BRAF, but we are talking about a different disease without a specific target therapy for many, many years. And importantly, these drugs seem to be effective also in case of commutations that typically are related to poor prognosis, such as the presence of STK11 or KEAP1, that are related to poor prognosis and to poor response to immunotherapy alone or in combination with chemotherapy. Toxicity profile was good, with low discontinuation rate due to treatment-related adverse events. The questions are, but what would be the role of these target therapies? We are waiting for the results coming from phase 3 studies in pretreated patients where the control arm was docetaxel, but there are a lot of trials ongoing that are evaluating the role of these inhibitors in the frontline setting in combination with other TKIs and in combination with immune checkpoint inhibitors. So we know we have now a lot of new driver alterations and new target therapies. Probably to date, we do not know yet what is the best setting where we should administer them. We still have to consider and to evaluate the role of immunotherapy alone or in combination for these alterations. But we know that they can be present and we must look for them because we have new drugs, some of them with a very good CNS activities. And of course, we have to pay attention to the toxicities related to these new treatments because they can be different from the toxicities that we are commonly see in our clinical practice due to the different mechanism of action of these new drugs. And with this, I thank you all for your kind attention.
Thank you very much, Diego, for your presentation. It is always a pleasure to listen to you like whole time. I think that this was the last presentation of our program, so I would like to thank again all the speakers. And now I think that we have about 15 minutes for the round table. Do we have any question from the audience? I think no question at the moment.
Okay, I have a question for all the speakers, especially for Dr. Felipe, but also for all the other speakers. Especially in ALK positive patients, do you think there may be a role for a sequencing drug strategy? Or the most effective drug must be necessarily used as first treatment?
Very important question, and we don't have the answer. It's true that in other situations, in patients with molecular alterations, we have used the best treatment upfront, no? Because we know that we can lose patients in each sequence. So I think it's true that we need probably longer follow-up of the CROWN trial, but I think in general in oncology, I prefer to use the most potent agent at diagnosis.
Okay. Dr. Gagil?
Yeah, I would agree. I never disagree with Dr. Philip, but no, I would agree. I think when it comes to ALK, there is now the question, should we start lorlatinib? Because as Dr. Philip showed, in the CROWN trial, the hazard ratio of lorlatinib was very good at 0.28 as opposed to 0.49 with both brigatinib and alectinib. And the way I have sort of resolved, but lorlatinib does have uncommon side effects like cognitive impairment, hypercholesterolemia, neuropathy, edema, that can be limiting. And one needs to be mindful that the ALK patients are generally younger patients than the average lung cancer patients, and therefore the impact of the disease may be even greater in this patient population, as well as the impact of the drug toxicities. And so, generally, wow, I have sort of resolved these different competing factors in my mind is that if patients has CNS metastases, particularly multiple CNS lesions, and has a heavy tumor burden, I prefer to start with lorlatinib because it appears that the benefit of lorlatinib, particularly against CNS, seems very impressive. But if patient doesn't have significant CNS metastases or doesn't have significant tumor burden, I prefer to go with alectinib.
Thank you. Dr. Rolfo?
Yeah, I completely agree with both of them. And the only thing that we can add at your question for next generation sequencing is true that could be interesting to know always the mechanism of resistance. But several of the data that we have obviously are coming from or cell lines or anecdotal case. So we don't have actually a big number of population to say that this drug is really better than others. So with the data that we have, and Dr. Felipe presented today with the lorlatinib, so we saw that these patients can receive the treatment and respond. So, but it's good from the academic exercise point of view to have this identification of mechanism of resistance, obviously.
Diego?
Just as an addition to what Christian Rolfo mentioned, this is where I think the liquid biopsy NGS or NGS on the tumor may be helpful. There is some data to suggest it's not conclusive data that patients with variant 3 may have a worse outcome, or patients who have co-mutations in P53 may have a worse outcome. So it is conceivable, and this is pure speculation. I'm not suggesting that we do that route that now. But patients who have maybe P53Q mutation or variant 3 is where we preferentially use a drug like lorlatinib, which appears to be more potent. And whereas in the patients who have variant 1 or don't have the co-mutation, we may still continue to use it. So there may be some level of selectivity based on these NGS tests. So the NGS tests, apart from their ability, whether it's liquid or tissue, apart from their ability to detect multiple mutations at the same time, have the ability to identify these maybe poor prognostic features that may tailor our treatment accordingly.
Absolutely.
Diego, we are interested also in your opinion.
Thank you, Giuseppe. I agree. I think that the best option should be the first agent. As Dr. Gagil said, lorlatinib has a different profile of side effects, and of course we have to learn the resistance mechanisms. And I hope, and I think that Christian agree, that liquid biopsy will have a more important role in the next future to look for mechanism of resistance for all these driver alterations.
Okay, thank you.
If no questions from the audience,
You can go.
I have a question for Dr. Rolfo, if I can.
Sure.
Yes.
In your opinion, will liquid biopsy ever be able to replace tissue sampling in clinical practice? Or do you think that tissue and liquid biopsy are complementary? Could it be useful to have both pieces of information in clinical practice?
So that's a very good question. I think the answer will depend obviously where we are trying to apply this. No, if we have in the first setting, so having patients without diagnosis, tissue diagnosis, I will say that tissue need to be there, obviously. And at this point, I will say that we have the opportunity to test complementary, because with the complete picture that we have with the liquid biopsy and the real-time opportunity to monitoring these patients is very useful. So we are using complementary approach. But for example, in patients that are in progression disease with TKI, having this liquid biopsy alone is enough. So if you have a liquid biopsy, and that is happening in our clinical practice, we have patients with liquid biopsy. I saw yesterday one patient that we had the result before. She was responding already to the treatment with the liquid biopsy, and we received after 3 weeks the tissue biopsy, that is very long time, and she was already responding to the TKI. So liquid biopsy is, if it's positive, we don't wait for the confirmation. When it's complementary, it's giving more opportunity to know about the clonal evolution. But mainly what is important, we need to have liquid biopsy from the baseline to compare what happened later on, because I saw several cases that are these differences between the first line or the baseline and the biopsy later on, the liquid biopsy using tissue and then liquid biopsy. And it's not really too easy to find or take conclusions on some patients.
Thank you very much.
Thank you, Dr. Rolfo. We have another question for you from the audience. What about liquid biopsy on liquor for differential diagnosis between metastasis and radionecrosis? Is it possible?
In liquor, you mean CSF? Yeah, we are actually working on that. There are several good opportunities in CSF. There we have actually a better purity of the DNA that you are collecting. Obviously, it's not the minimal invasive situation that we was talking with blood, but it's a good source of material, especially in patients that are having progression only in the brain, and with some inhibitors that they are having differences in mechanism of resistance when they have even actually intra or extracranial disease. So having this or collecting these differences is very important. And one of the institutions that have a lot of experience on that is Memorial Sloan Kettering. They just published something or presented in World Lung Cancer some data on CSF. We are expecting the manuscript to come in out soon, but it's a very good opportunity for the patients.
Another question for all the speakers. As you have just shown, we have a lot of target therapies for metastatic settings, and so we always need a comprehensive biomolecular characterization for this setting. But what about the early stages? I mean, according to recent results, IO could soon arrive in the early stage. Do you think that we need also a biomolecular characterization in these stages?
Enriqueta, you can start. I think you are
Dr. Felep first.
Yes. Thank you for the question. Very important. It's true that I think at least in Spain there are a different situation in academic centers. I think in general there is no clear recommendation of testing in patients with early stage disease. We don't have the reimbursement of osimertinib yet, but it's true that we have started to do that, to do NGS, at least in my institution, in patients with resected tumors. I think it's important information, perhaps not it's relevant to know that the patient has an ALK rearrangement if the patient has a resected stage 1 disease, but there is a lot of information even for the potential future treatment options. So I think everything is changing. I think there is a need of testing EGFR mutation. Probably I would agree that for me it's important to have also NGS and PD-L1, probably, yes, not only for adjuvant strategies. Also, in the Checkmate 816, the data presented seems to indicate that those patients with PD-L1 high are those patients that were more responsive to chemo plus immuno. So, yeah, I think there is a need for testing in patients with early stage disease.
Dr. Gagil.
I would agree. In the US, osimertinib has been approved for early stage lung cancer based on the ADURA results, and recently atezolizumab was approved based on the Empower 10 results. So because of that, we are now routinely testing for NGS as well as for PD-L1. I will say that in fact, with now the approval of atezolizumab, the NGS results have become even more relevant because I think that the Empower 10 results suggest that the benefit may not be the same in EGFR and ALK patients. And so your choice of therapy, irrespective of the PD-L1, may be dependent on the NGS results once these drugs get approved. So I would completely agree. And I think based on what Dr. Rolfo presented, I think the really promising data regarding MRD after resection is something that is very fascinating. So testing is going to become very integral in management of early stage disease, very similar to advanced stage lung cancer.
Dr. Rolfo?
Yeah, and nothing to agree what Enriqueta and Shirish they just mentioned. I think it's important that we open the door for other biomarkers, and there are several trials now that will imitate or mimic a little bit the DAURA trial, and it's important because we have these patients with different alterations, and even in stage 3 that are under chemoradiation, when we have still durvalumab, and we saw the data presented this year from Gustave Roussy with this difference in patients with target alterations. So I think it's a need that we need to cover.
Diego?
It's a very good question. But first of all, we should perform NGS at the moment of the diagnosis of advanced disease. It's not so common to have an NGS before starting a first-line treatment. Regarding the early stages, I think that now, in this moment, except for clinical trials, I will perform the alterations that have a clinical relevance, such as EGFR mutations for osimertinib, adjuvant osimertinib, or PD-L1 for unresectable local advanced non-small cell lung cancer. I don't know when atezolizumab will be reimbursed in Europe and in Italy. What would be the criteria? PD-L1 over 1%, over 50%, EGFR and ALK negative. So I think that at the moment in the clinical practice, I will perform only the alterations that have a clinical relevance. Of course, as Dr. Gadgil mentioned before, I think that MRD will have an important role in the next future in the adjuvant setting. There are some clinical trials designed using MRD, and also in the neoadjuvant setting.
Okay, thank you. Do we have any other question?
I think that the time is over, unfortunately.
Okay, thank you for your answer. We would like to go on with this very, very interesting discussion, but the time is over. So thank you again for your presence. And now for the last time this year, it's the time of the cocktail show. Thank you.
Thank you.
That's it. Thank you.
Thank you.
Hello everyone, I'm Alberto Catalani and today I'm your virtual bartender. Today I'm gonna make a drink that is a very mysterious drink. Is the South Side. The South Side comes from Chicago, and many people say that was the best drink for Al Capone. I'm Italian, but I'm not a gangster. We put 50 ml of London dry gin, 30 ml of fresh lime juice, and 15 ml of sugar syrup. And we're going to put some mint leaves because the drink will be green, and we put some ice in the glass, and we going to put the ice in the shaker, and we have to shake very, very well. And we go to pour and strain because there are a bit of mint inside. Okay. We garnish with the mint springs, and you can take some potatoes and salute.
Chin. At the end of our conference, I would like only to say thank you to all the chairs, all the speakers, and all the people connected from home. I would like also to say thank you to all the sponsors who make possible this conference. I hope he will. I hope that in the next year we will stay again with in presence. Thank you very much.
Bye.
Bye.
Bye, ciao.
Bye, thank you.